So today we're going to take an in-depth look at local anesthetics and how it relates to regenerative medicine. We're going to start at the very beginning with a plant called Erythrooxylum coca. The discovery of local anesthetics originated from Erythrooxylum coca, known as the coca plant. The coca plant is where the alkaloid of cocaine, erythrooxylin, is derived from. The coca plant is indigenous to South America in Peru, Bolivia, and Colombia. Coca leaves are part of culture and is used as tea, food, and medicine. If you ever go to Peru, you'll easily find coca leaves to chew on or to drink as tea. It is natively used to help with altitude sickness, gastrointestinal complaints, pain, and fatigue. A large amount of coca leaves are needed into cocaine. About 200 to 800 kilograms of coca leaves are needed to make 1 kilogram of cocaine paste. And the cocaine content of unprocessed coca leaves is about 0.13% to 0.68% of erythrooxylin. The chemical purification of the coca plant into cocaine increases its toxicity and addictive properties. As many of you already know, cocaine is related to many overdoses and cartel-related deaths. By 1855, the German chemist Friedrich Gadig had separated erythrooxylin compound, also known as cocaine, from coca leaves. In 1859, Albert Niemann isolated purified cocaine. In 1865, Albert Niemann's student, Wilhelm Lawson, determined cocaine's molecular formula, as you can see here, 17 carbon, 21 hydrogen, 1 nitrogen, and 4 oxygen. Basil von Enriep, in 1880, published the results of his studies concerning the application of cocaine to humans. In the conclusion of his work, he recommended cocaine as a surgical anesthesia. In 1884, Carl Kohler used topical cocaine for the first surgery, which was a cataract surgery. So cocaine now obviously is illegal to use as a local anesthetic. However, it led to the discovery of other local anesthetics. In 1905, the first pharmaceutically derived local anesthetic from cocaine was created, an ester local anesthetic called Procaine. This anesthetic was not the ideal local anesthetic because of its very long onset, short duration of action, low potency, and allergic potential. Since the discovery of cocaine, many variations of local anesthetics were created. In the 1940s, the first amide local anesthetic was synthesized, lidocaine. Since the 1940s, many variations of amide local anesthetics have been created, based on their onset, toxicity, potency, and duration of action. In 1957, the second amide local anesthetic was synthesized, bupivacaine, also called Marcaine. There are two major classifications of local anesthetics, amides and esters. The amide local anesthetics are listed here: lidocaine, mepivacaine, bupivacaine, levobupivacaine, prilocaine, ropivacaine, and atidocane. The ester local anesthetics are procaine, 2-chloroprocaine, tetracaine, cocaine, and benzocaine. Local anesthetics are classified as either an amide or an ester local anesthetic based on their chemical structure. This determines its chemical stability, metabolism, and allergic potential. Amides tend to be more stable, and esters are more unstable. There are three major components to their structures. On the left here, you see the aromatic portion, then the intermediate chain, and then the amino group on the side. So each component of these that I just talked about of the local anesthetic contributes a distinct property to the local anesthetic. The constituent of the intermediary chain determines whether the local anesthetic is classified as an aminoamide or an amino ester type local anesthetic. The aromatic portion of local anesthetics determines its lipid solubility, which allows anesthetics to cross nerve sheaths and cell membranes. The amine group is the hydrophilic portion or the water-soluble portion. This acts as an on and off switch for lipid and water solubility, which depends on the number of bonds attached to it. It exists as a tertiary amine with 3 bonds and is lipid soluble, or it can also exist as a quaternary amine with 4 bonds and be water soluble. The main types of amide local anesthetics used in regenerative medicine are ropivacaine, brand name Neuropin, brand name xylocaine, and bupivacaine, brand name Marcaine. This graph represents their pharmacokinetics that can be used to determine what the best anesthetic is. It is important to be safe when using local anesthetics, but calculating the max dose for each patient can be repetitive, so I calculated the max dose for a 100-pound patient for each of the local anesthetics, as you can see here at the bottom. Since most adults will be over 100 pounds, this can give you a ballpark understanding of what a safe dose of local anesthetic would be. So looking at ropivacaine, the max dose is 3 milligrams per kilogram, or the total max dose of 300 milligrams or 60 cc's. And the calculation, I've even written it out here for you, for a 100-pound patient is 20 cc's or 27 cc's or 27 milliliters. And then the max dose for lidocaine would be 4 milligrams per kilogram with a total max dose of 300 milligrams or 30 cc's, with the max dose for a 100-pound patient being 18 cc's. For bupivacaine, it's 2 milligrams per kilogram with a total max dose of 175 milligrams or 70 cc's, with for a 100-pound patient being 36 cc's. For levobupivacaine, the max dose is also 2 milligrams per kilogram with the total max dose of 175 milligrams or 35 cc's. The max dose for a 100-pound patient would be 18 cc's per milliliter. And you can tell that the difference between this is if you look at the potency of this bupivacaine is 0.25% versus levobupivacaine is 0.5%. And so that's where the differences are coming from there. The one with the shortest onset time, as you can see, was lidocaine, and then is bupivacaine, levobupivacaine, and then finally ropivacaine. The one with the longest duration is levobupivacaine, next ropivacaine, then bupivacaine, and finally lidocaine. For ester local anesthetics, procaine is the most commonly used, but I also wanted to give it a comparison, so I also put another local anesthetic that we're going to be talking about in this lecture, chloroprocaine, but it's not commonly used in regenerative medicine. The max dose for procaine is 7 milligrams per kilogram with a total max dose of 500 milligrams or 50 cc's, and the max dose for a 100-pound patient is 32 cc's. For chloroprocaine, it was 11 milligrams per kilogram, total being 800 milligrams or 80 cc's, with the max dose for a 100-pound patient being 50 cc's. So to compare with the mild local anesthetics, procaine has a longer onset time than lidocaine, but a shorter onset time than ropivacaine. Its duration is longer than lidocaine, but shorter than ropivacaine and bupivacaine. So overall, we can see that you would generally have to inject a lot of local anesthetic in the periphery to reach the max dose. And usually we're not going anywhere near these max doses when we are doing regenerative medicine injections. So now let's review some foundational organic chemistry to make sense of the differences between certain local anesthetics. Isomers are molecules that have the same molecular formula. For instance, the molecular formula of lidocaine has 14 carbon, 22 hydrogen, 2 nitrogen, and 1 oxygen. The term isomer can be further broken down into structural isomer, also known as a constitutional isomer, and stereoisomers. Structural isomers have the same molecular formula with different connectivity. They don't usually have chiral centers. And for example, I have in a picture here the graphic of butane and isobutane, which they have the same molecular formula but are arranged differently. So that would be structural isomers. Stereoisomers have the same molecular formula, are arranged differently in 3 dimensions, and have chiral centers. So molecules with chiral centers exhibit stereoisomerism. A chiral center is usually a carbon atom, could also be sulfur, phosphorus, or nitrogen, with 4 different substituents attached to it. There are 2 types of stereoisomers, optical and geometric stereoisomers. Optical isomers are also known as enantiomers. 2 examples of enantiomers are levorotary, which can be labeled as L, S, or negative, which rotate light counterclockwise or to the left, and dextrorotary, which is labeled as R, D, or positive, which rotates like clockwise or to the right. Geometric isomers have the same connectivity but differ in three-dimensional arrangements around a double bond. So we're going to be talking about optical isomers as it relates to local anesthetics. So for drugs, chirality significantly affects the drug's biological activity. With relationship with local anesthetics, isolation of a stereoisomer in a racemic mixture can improve its toxicity. The best example is with the MI-type local anesthetics, bupivacaine and levobupivacaine. Bupivacaine is a racemic mixture of both L and R stereoisomers. Levobupivacaine isolates the L isomer. Research shows levobupivacaine has less toxicity than bupivacaine with similar pharmacokinetics. Levobupivacaine has less cardiac and central nervous system toxicity. It is proposed that this happens because the racemic or R isomer have a great affinity to sodium channels in cardiac myocytes and cause more of a dramatic decrease in the rate of depolarization in cardiac myocytes. Newer local anesthetics like ropivacaine isolate the L enantiomer and have less toxic symptoms. The next term, pharmacodynamics, refers to the effect of drugs and their mechanism of action. This next section is a quick review of some neuroanatomy and physiology and then how it relates to local anesthetics. So nerves are organized into two major types based on anatomy, myelinated and unmyelinated. Myelin increases the speed of the signal from the periphery to the brain. These are the following classifications of nerves based on their degree of myelination from greatest to least, shown here. So the three that are relevant to pain are alpha gamma, alpha delta, as well as the C nerve fibers. Resting membrane potential is the electrochemical difference of charges across the membrane at rest. Positively charged cations line the outside of the neuronal membrane and negatively charged anions line the inside of the neuronal membrane. The membrane is impermeable to sodium cations and permeable to potassium cations. This electrochemical gradient is maintained by ATP sodium-potassium pumps. This pump exports 3 sodium out for 2 potassium into the neuron. The resting membrane potential of a neuron is more negative on the inside at negative 70 millivolts. When a stimulus is felt and reaches a certain threshold, an action potential is felt and the resting membrane potential moves to be more positive, causing a depolarization. This action potential is allowed to happen because voltage-gated sodium channels are allowed to open and sodium rushes into the neuron along its concentration gradient. The membrane resting potential is restored after sodium channels close and potassium channels open, repolarizing the neuron. The voltage-gated sodium channels we just mentioned, which you can see an example for in this picture, the local anesthetics bind on the inside at the alpha subunit, inactivating the channel. And by inactivating the voltage-gated sodium channels, it stops action potentials from propagating along the nerve. Without action potentials, no information or pain signals can be sent back to the brain. Different aspects of local anesthetic structures influence their function in the body. In the next few slides, we're going to talk about these differences. The pH of local anesthetics affect its onset time. Before we go into that a little bit more, we're going to do a quick review of some pH chemistry. The Henderson-Hasselbalch equation, which you can see here, is used to estimate the pH of a solution. pKa is based on the acid dissociation constant, which determines its ability to donate a proton. In a solution, the pH equals the pKa when 50% of the acid is dissociated into its conjugate base. A hydrogen atom, also called a proton, when discussing acid-base. The ionized form has a charge and thus is hydrophilic. The non-ionized form has a neutral charge and thus is lipophilic. And we're going to go into a little bit more here about why that is important. So, local anesthetics must be lipid soluble to penetrate the neuron to reach the active site at the voltage-gated sodium channel inside the neuron. Thus, it must be in its neutral form to cross the neuronal membrane. In a syringe, local anesthetics exist in a stable solution as a water-soluble quaternary salt, which is protonated, ionized, and hydrophilic. When the pKa is greater than the pH, it will also exist predominantly in its ionized quaternary salt form. The closer the local anesthetic is to the pKa, to the physiological pH of 7.4, the more local anesthetic will be dissociated into its non-ionized. Inflamed tissues will also affect the ability of local anesthetics to work. It tends to cause tissues to be acidic, which would cause local anesthetics with a higher pH to be less effective. A trick you can do to favor the lipophilic form is to increase the pH by adding sodium bicarbonate. This will increase the speed of onset by increasing penetration into the neuron. The more lipid-soluble the anesthetic is, the greater the ability to cross the neuron's lipid-soluble membrane, thus providing it with the shorter time to onset. If you look at this graph here to the right, you see that the quaternary salt is dissociated into the deprotonated tertiary salt. The deprotonated form crosses the epineurium and the neuronal membrane to reach inside the cell to act on the voltage-gated sodium channels. Once inside the cell, the local anesthetic must gain a hydrogen atom to form its quaternary structure. The protonated quaternary salt is what acts on the active site of the voltage-gated sodium channels. The potency of a local anesthetic is the minimum dose of local anesthetic that can be used to cause a complete nerve block. A higher potency local anesthetic allows for lower amounts of local anesthetic to be used. Potency of a local anesthetic is closely related to its lipid solubility and pKa. Lipid solubility of the local anesthetic determines its ability to penetrate lipid-rich nerve sheaths and cell membranes. This is important because, as you remember from before, local anesthetics block voltage-gated sodium channels from the inside of the neuron. Local anesthetics lipid solubility is affected by two things. It's aromatic ring and aliphatic substituents at the designated R groups in the picture shown here. By increasing the length of its carbon backbone, this will increase its lipid solubility. Lipid solubility also affects the rate of absorption. Lipid-soluble agents are absorbed more slowly and stay around longer. Protein binding of local anesthetics also correlates with the duration of the local anesthetic. It happens to be that local anesthetics with higher molecular weight and lipid solubility tend to have higher protein binding. The affinity of local anesthetics to plasma proteins mirrors its affinity for proteins at voltage-gated sodium channels. Thus, local anesthetics with higher protein binding capacity will bind to the active site for longer periods of time. Vascular absorption also affects duration, which we will discuss more here in a little bit. So now we're going to review the pKa and protein binding for the major local anesthetics used. The physiology of local anesthetics is mostly consistent with the clinical data for local anesthetics, with some variations. Ropivacaine has the highest pKa, as you can see here, 8.1, and it has 17 carbons. We would expect it to have a longer time to onset and a longer duration, which is consistent with what we had talked about before. Lidocaine has the lowest pKa out of all of them, and has the quickest time to onset and the shortest duration, which is also consistent. Bupivacaine has the same pKa as ropivacaine, but has a shorter time to onset. This could be because it has an extra carbon on its aliphatic chain, causing it to be more lipophilic, but I'm not really sure. It was just kind of something that I conjectured because that didn't seem to be very consistent. So procaine and chloroprocaine, we would have expected them to have the slowest time to onset out of all of them because the pKa is the farthest away from the physiological pH of 7.4. However, ropivacaine had the slowest time to onset. It also has the least amount of carbons and hardly any protein binding. We would expect the duration to not be very long, which is mostly true. Lidocaine was the only one with similar duration. However, lidocaine had significantly more protein binding. Procaine and chloroprocaine time to onset is similar to bupivacaine, which is interesting because their pKa is higher. Pharmacokinetics is the movement of drugs within the body. We're going to specifically talk about absorption, distribution, and metabolism in this section, and how these factors affect peak plasma concentration and allergic potential of local anesthetics. Absorption is determined of how fast a local anesthetic reaches the blood. Absorption is related to the vascularity of the injection and the vasoactivity of the injection site as well. All local anesthetics cause vasodilation by relaxing vascular smooth muscles, with the exception of cocaine. The rate of absorption is also affected by the location of the injection. The highest absorption rate is intravenous, obviously, and then it goes in decreasing order: intercostal, caudal, epidural, brachial plexus, femoral, sciatic, and subcutaneous. And also, if an area is more vascularized or inflamed, local anesthetics will be cleared more quickly from the area. After the local anesthetic reaches the blood, the rate at which local anesthetics distribute to tissues depend how fast those tissues are perfused. Rapidly perfused organs are, as you can see here, brain, myocardium, liver, lungs, and also kidney and spleen. Slowly perfused organs are adipose and muscle tissue, which is where we inject most regenerative injections. Peak blood concentration of local anesthetics is directly proportional to the dose and indirectly proportional to cardiac output and the time of injection. There should be a graphic here that's not loading that shows that, that relationship. So sorry about that. Peak plasma concentration is usually the venous concentration after injection with local anesthetic. This is used to determine toxicity. We will also talk about studies that measure arterial peak plasma concentration and how it relates to local anesthetic toxicity. This graph looks at the absorption of mepivacaine, lidocaine, prilocaine, and atidocane. We're going to focus on the section that talks about lidocaine. Remember that intercostal injections have the second highest absorption rate, second to injecting directly into the vein. In this study, the peak concentration of lidocaine was checked at 15 minutes after an injection was given over 1 minute. Intercostal injection of 400 milligrams of lidocaine brought plasma concentrations up to about 6.3 micrograms per milliliter. Just as a note, you usually begin to see toxic symptoms when blood concentrations reach about 5 micrograms per milliliter. Remember, the total max dose for 1% lidocaine is 300 milligrams or 30 cc's of 1% lidocaine. According to this, it seems that you would need to inject it around the maximum dose in the periphery to possibly see toxic symptoms. As you can see here, the peak plasma concentration does vary based on the location of the injection and the type of local anesthetic used. The amide or ester chain between the aromatic portion and the amino group in local anesthetic determines its classification and how it will be metabolized. The ester type local anesthetic, like procaine, are metabolized in the blood, and the amide type local anesthetic, like lidocaine and ropivacaine, are metabolized in the liver. Since ester type local anesthetics are broken down in the blood to PABA, or para-aminobenzoic acid, less toxicity from them has previously been noted. The chart here shows the results from a study that showed how fast procaine, 2-fluoroprocaine, and tetracaine were hydrolyzed into its para-aminobenzoic acid infusion. Administration of local anesthetics was terminated after 25 minutes of 1 milligram per kilogram per minute, or when toxicity symptoms of generalized twitching, convulsions, breathing difficulties, loss of consciousness, or severe disorientation occurred. Chloroprocaine was 4 times faster than procaine to hydrolyze into PABA. Chloroprocaine resulted in 7 times higher. 2-chloroprocaine was tolerated the best out of all of the local anesthetics tested. For 25 minutes after the injection of local anesthetics, 10 out of the 12 tolerated chloroprocaine, 3 out of the 12 tolerated procaine, and 0 out of 12 tolerated lidocaine. So now that we understand generally how toxicity works between amide and ester local anesthetics, let's compare their allergic potential. Ester-type local anesthetics like procaine are more well known to cause an allergic reaction. Amide-type local anesthetics have rarely been implicated in an allergic reaction. What is the difference between an ester local anesthetic and an anesthetic that contains an ester side chain? The difference is how they are metabolized and what their metabolites are. Remember, procaine is an ester-type local anesthetic that has an ester linkage in the intermediate chain that links the aromatic ring and the amino group. Articaine, as you can see here, is an amide local anesthetic which combines an aromatic ring and an amine group via an amide linkage. Articaine has an ester side chain coming off of its aromatic ring. Neither of these esters are what cause local anesthetics to have an allergic reaction. It's the para-aminobenzoic acid byproduct of when local anesthetics are hydrolyzed that causes an allergic reaction. Chloroprocaine, as we remember from a couple slides ago, was better tolerated but created more PABA. This local anesthetic, even though it causes less toxicity, has a higher allergic potential. One of the major types of allergic reactions that occur with local anesthetics is an immediate type 1 hypersensitivity reaction. This reaction occurs when the immune system recognizes large foreign proteins in the body. However, PABA is a small molecular weight molecule that is recognized by the immune system because it is attached to a carrier protein, allowing it to be large enough to be recognized by the immune system. The drug metabolites are often called haptens. Haptens are the small molecules that combine with the carrier protein to be transported into the blood. The hapten and carrier protein complex becoming large enough to be recognized by the immune system to cause an allergic reaction. And you can see that here in the graphic. There are 4 types of allergic reactions to procaine, though, and that is just the one that we are most familiar with. There's also contact dermatitis, atopic reaction, serum sickness pattern, and accelerated serum type. Contact dermatitis results from topical exposure to local anesthetics. This can easily be tested for in a patch test. An atopic reaction is the type 1 hypersensitivity reaction we talked about that can cause bronchial asthma, urticaria, angioneurotic edema, and possible death. The serum sickness pattern is a reaction that can occur 2 to 12 days after the first injection with procaine. That means your patient could have an allergic reaction to the local anesthetic after they leave your office days after the injection. The reaction may include urticaria, fever, joint pain, and lymph node enlargement. This is usually a benign response, though. Accelerated serum type also is what I think is the most scary one out of all of these. The onset is sudden and severe. This results from sensitization by smooth muscle antibodies. This cannot be tested for in a patch test because it's mediated by different antibodies than in atopic. The reaction includes shock, respiratory distress, capillary congestion, visceral congestion, dilation of the right side of the heart, alveolar transudation, and possible death. And what makes this one scary to me is that it's hard to predict how your patient will react to the local anesthetic. And that's because they could have however many injections and still have an allergic reaction. And with the serum sickness pattern, they could have a reaction even days after they had an injection. So now I want to go through a few cases with you guys that show fatal reactions to procaine local anesthetic. This first case is of a 58-year-old male who presented with blood pressure of 160/90 with status asthmaticus. Procaine had been given to this patient before to treat his status asthmaticus without any adverse reaction. He was hospitalized again years later for the same condition, and he was given an unknown dosage of procaine and died as a result of procaine allergy.